Kia ora. Today we're talking about addressing inequity in primary care using the treatment of gout as an example. My name is Susan Reid and I work for Health Literacy NZ. I'm also the coordinator for Gout Action Aotearoa. Before we start, I'd like to thank my colleagues at Gout Action Aotearoa, particularly Doctors Nicola Delbeth, Peter Gow, Bruce Errol and Tony Merriman for their support with this material. One of the biggest challenges in thinking about equity is differentiating it from equality. Equality is about treating people the same, while equity is about treating people fairly. Equity is about being prepared to work differently, to give people the same opportunity to achieve good outcomes. As someone at Counties Manukau said, it's about being regardful of people's ethnicity, their gender, locality and socioeconomic status, rather than thinking about treating them regardless of those things. The first picture assumes everyone will benefit from the same supports. In the second picture, the individuals have been given different supports so they can have equal access. And in the third picture, everyone can see the game without extra supports because the cause of the inequity, the system structures and biases that caused it, have been dismantled. Why is equity important? We all know that a whole range of health outcomes for Māori and Pacific peoples are worse than outcomes for New Zealand, European, Asian and others. Addressing equity means addressing the reasons for those poor outcomes and improving health outcomes as a result. Gout is an example of inequality in relation to who gets gout. And gout is also an example of inequity in relation to treatment. So inequality is something unequal and in the case of gout, unavoidable. For example, Māori and Pacific men are genetically more likely to develop gout and at an earlier age. Inequity is something unnecessary, avoidable, unfair and unjust. For example, if Māori and Pacific men get gout at higher rates, then equity would mean that Māori and Pacific men would receive greater rates of treatment for gout, consistent with their rates of gout, and at an earlier age than New Zealand, European, Asian and others. And that's not the case. So who gets gout in Aotearoa, New Zealand? In 2016, approximately 182,000 people aged 20 years and over were identified as having gout. This data has come from the Health Quality and Safety Commission's Atlas of Healthcare Variation. The biggest population group with gout is New Zealand, European, Asian and others, and that's what you'd expect because they're the biggest population group in New Zealand. But the prevalence, what people think of as the rates of gout, are different in different populations. Out of 100 New Zealand, European, Asian and other people, 4 will be identified with gout. But out of 100 Māori, 8 will have gout, and out of 100 Pacific, 14 will have gout. There is a higher prevalence of gout for Māori and Pacific men in all age groups. As you can see, Māori and Pacific men start to get gout much younger than New Zealand, European, Asian and other men between the ages of 20 and 44. This is a significant time in these young men's lives when they're working, they've got young families, they're playing sport and they're participating in family and community events. If men at that age can't work because of poorly treated gout, then this impacts negatively on their lives and their families' lives. So why is there such a problem treating gout? The issue is that people are treated for the symptom, not the underlying cause. If people present to primary care or ED with a very painful gout attack, then the appropriate treatment is pain relief. However, because of the genetic factors, Māori and Pacific men are much more likely to have frequent and increasingly painful gout attacks. When these men are given pain relief, they're only being treated for the symptom and not the cause of their gout. The cause is high levels of uric acid because their genes affect how their kidneys get rid of the uric acid from their body. And the only way to address the cause of gout and stop having gout attacks is to bring uric acid levels down by taking long-term medicines such as allopurinol. So let's look at the inequities in the treatment of gout. This graph does have a different scale on the y-axis for each line, but it's the shape of the graph that's important. The red line shows the prevalence of gout. Remember, Māori and Pacific have 2 to 3 times the prevalence of gout compared to New Zealand, European, Asian and others. And the blue line is about admissions to hospital due to gout. Māori have 5 times and Pacific peoples have 10 times the admissions to hospital than New Zealand, European, Asian and others. So if there was equity in treatment, the dotted green line would be what you would expect in terms of who receives allopurinol. Because of the inequity, the solid green line shows the reality of treatment. So the groups who have the lowest rates of gout are more likely to be receiving allopurinol, while Māori and Pacific peoples with much higher rates of gout are less likely to be receiving allopurinol. And for Māori and Pacific peoples, equity in gout would be achieving at least the current allopurinol dispensing rate for New Zealand, European, Asian and others who have gout. In fact, we actually need to go beyond equity to achieve best practice. For Māori and Pacific peoples with a higher burden of disease and impact of gout, beyond equity would mean higher rates of receiving regular allopurinol to control their gout. So equity requires doing things differently. For providers, equity would mean encouraging or incentivising primary care practices to do things differently for Māori and Pacific peoples with gout. For the health workforce, equity would mean having different conversations with Māori and Pacific peoples with gout. Focus on genetic causes, the need to take long-term medicine to treat causes of gout. Ask about the impact of their gout on their family, work and social situations. Share your concerns about the long-term impact of gout. For Māori and Pacific peoples with gout, their families and communities, equity means building knowledge about the causes of gout and genetic factors, dispelling the beliefs that mean they feel that getting gout is their fault, and instead talking about the need to take long-term medicine to reduce the amount of uric acid in the body. And the health system could help with this by providing an effective national public awareness campaign about gout. So here's some things you can do in your practice. Do a query builder for patients with gout. Follow up Māori and Pacific patients. Recall them for a free appointment or invite them to a shared medical appointment about gout. Link uric acid tests to other screenings such as CVD risk assessments or diabetes foot checks. Add gout to your dashboard. Consider working with your local pharmacist to set up a community gout management service. And invest in a point of care meter so you can test uric acid levels in your practice. The next time a Māori or Pacific patient comes in with a gout attack, don't talk to them about the food or drink they've had recently. Instead, talk to the patient about gout not being their fault. It's about their genes, and talk about a long-term plan for their gout. Persevere with these conversations. It may take some time for patients to realise they need to do things differently, and see that taking medicines is a sign of well-being rather than sickness. In summary, inequity is unnecessary, avoidable, unfair and unjust. Differences in treatment of gout and treating everyone the same contributes to this inequity. Primary care providers have a critical role to play. We have to address the systems, structures and biases that support this continued inequity across a wide range of health conditions such as gout. Equity requires doing things differently. For more information on shared medical appointments, visit smstoolkit.nz. For other health information, visit healthnavigator.org.nz. Kia ora.